This video will cover the pathophysiology of cystic fibrosis. Cystic fibrosis, or CF for short, is an autosomal recessive inherited disease. Autosomal recessive means that two copies of a mutated gene are required in order for the disease to be expressed. CF is a multisystem disease that is characterized by secretions of abnormally viscous or thick body fluids. And this is especially prevalent or evident in the pancreas, the lungs, and the sweat glands, as we will see when we talk about the clinical presentation of this disease. There are currently about 30,000 individuals in the US that are diagnosed with CF. The incidence or number of new diagnoses of CF is about 1 in every 2 to 4,000 live births. As you can see in the bottom half of the image here, the number of new CF diagnoses per year has not changed substantially in the last 20 years. However, one of the things that has changed is the way that cystic fibrosis is diagnosed. More and more, as time goes on, CF is diagnosed by newborn screening, or NBS for short, indicating that this disease state is able to be detected essentially at birth. In terms of people currently living with cystic fibrosis, about 56% of them are adults 18 and older, and about 44% of them are children. The number of adults living with CF has steadily increased over the last 30 years, owing to advances in treatment and management of the disease state. Previously, the life expectancy for individuals with CF was significantly shorter, and that's why if you look to the earliest years of this figure in 1989, only 30% of the individuals living with CF were 18 years and up. Given new and better treatments, individuals with CF are now living longer, healthier, and more quality lives. And there are many individuals over 18 that can function even in the presence of this genetic disease. In children and young adults, cystic fibrosis is the most common cause of severe chronic lung disease. Currently, the median age of survival as of 2019 is about 48 years. Keep in mind that this means about 50% of patients will live longer than 48 years, and the other 50% will live shorter than 48 years, which is a significant increase in life expectancy over the last several years, as I will demonstrate at the end. Cystic fibrosis incidence varies significantly by race or ethnicity. It is much more common in individuals of Caucasian descent than in other ethnicities. In fact, cystic fibrosis is the most common genetic disease in Caucasian individuals, occurring in about 1 in every 2,500. Individuals of Hispanic, African American, Asian American, or Native Hawaiian Pacific Islander descent have a much lower chance of developing cystic fibrosis, somewhere between 1 in 15,000 and 1 in 100,000 in some cases. Another thing that is important to consider when talking about an autosomal recessive disease state is the estimated rate of symptomless carriers. These are individuals that have one copy of a mutated gene and one copy of the fully functional gene, and typically do not express the cystic fibrosis disease. However, if they were to produce offspring with another symptomless carrier, the chances of producing an offspring with two mutated copies that does have cystic fibrosis is much higher. The symptomless carrier rate in individuals of European American descent is somewhere on the order of 1 in every 28 individuals, whereas you can see the symptomless carrier rate is much less frequent in other populations like African Americans. As I mentioned earlier, cystic fibrosis is caused by autosomal recessive inheritance of mutations in a single gene, and this gene encodes for a protein called cystic fibrosis transmembrane conductance regulator, or CFTR for short. There are over 2,000 identified mutations, not all of which cause dysfunctional proteins. As I will demonstrate shortly, these mutations are divided into 6 classes depending on the effects they produce in the CFTR protein. Even though there are many possible mutations, there are some that are significantly more common than others. The most common by far is the phenylalanine 508 delete mutation, or F508 delete. This occurs in approximately 85% of individuals with cystic fibrosis, and there is not any other gene that comes close to that level of prevalence. Some of the second and third most common genetic mutations are shown on this slide, which are a G to X mutation at amino acid 542, a G to D mutation at amino acid 551, and an R to H mutation at amino acid 117. The F508 delete mutation results in a CFTR protein that is truncated or chopped off after amino acid number 508, meaning the protein is much shorter than it normally would be. Of the individuals with this mutation, approximately 45% of them are homozygous for this mutation, meaning they have 2 copies of F508 delete. 40% of individuals are heterozygous, meaning they have 1 F508 delete mutation and 1 alternate mutation on their other chromosome. About 15% of patients have neither the F508 delete mutation or their mutation is not known. Even though there are already over 2,000 possible mutations that have been identified, more are being identified all the time. The primary genetic tests that look for CFTR mutations only test for the top 100 to 150 most common mutations. Therefore, it is possible for someone to have a CFTR mutation that causes cystic fibrosis that has not yet been identified or discovered. Given that CF is a genetic disorder, the 2 primary risk factors are having a positive family history and being of Northern European ancestry. Cystic fibrosis transmembrane conductance regulator, or CFTR, is a chloride channel found in many organs in the body. I'm going to use the CFTR function in sweat glands as an illustration to describe how CFTR normally functions. As a chloride channel, one of the main activities of CFTR is to regulate fluid and electrolyte balance in epithelial cells. These are cells that line the airways, pancreatic ducts, sweat glands, among other organs. The CFTR protein is always found on the apical membrane of epithelial cells, which is the side facing the lumen, or the area where fluid collects. One of the most important things to note about cystic fibrosis transmembrane conductance regulator is that it transmits or transports chloride ions across the apical membrane of epithelial cells. The key thing to remember about this transfer of chloride across membranes is that chloride ions, sodium ions, and water like to stay together. If you remember that one fact, it will help you better understand how dysfunction in CFTR leads to the expression of cystic fibrosis. I'll say it again because it's extremely important. Chloride ions, sodium ions, and water are always together. In a normal sweat gland, as illustrated in the left portion of this figure, CFTR reabsorbs chloride from the lumen to decrease the amount of sweat that is released and to decrease the salt content of sweat. When chloride is reabsorbed into the cell, sodium follows and then water follows, and there is less sweating and less salt content in the sweat that is released. Mutations in the CFTR gene result in a CFTR protein that is not functional, as illustrated on the right half of this image. If CFTR is not functional, chloride cannot be reabsorbed into the cell. This results in chloride being retained in the sweat, as well as sodium being retained in the sweat and water staying together with chloride and sodium. This leads to increased sweating as well as an increased salt content of the sweat. So the sweat will become more salty than normal. The same principle of chloride, sodium, and water being together is true of CFTR function in the lungs. Again, CFTR is found on the apical membrane facing the lumen of the airway. In normal lungs, shown in the left half of this figure, CFTR secretes chloride into the airway ducts. So in this case, the normal function of CFTR is to release chloride into the lumen of the airway. When chloride is released into the lumen of the airway, this results in sodium and water being retained or staying with the chloride in the airway duct, and that helps control the normal viscosity of mucus. We do not want mucus to get too thick in the airway lumen, and therefore secreting chloride into the lumen is a way to keep airway mucus hydrated and mobile. In the case of cystic fibrosis, again, the CFTR gene is not functional or dysfunctional and therefore is really not present and active on the apical membrane. In these lungs, chloride cannot be released into the airway lumen to hydrate mucus and keep it functional. Because chloride cannot be released, chloride, sodium, and water are all retained within the cell, and the mucus becomes very dehydrated, very thick and viscous, and difficult to clear through the airway. The accumulation of viscous mucus in the lungs also results in a chronic pro-inflammatory state and abnormal local immune defenses, which I will talk about on a subsequent figure.